All right. Hello, everyone. It's just me on my lonesome for this session because I'm speaking to you from the past. Our exams are literally going on as you're watching this. So we've recorded these sessions in advance. So that's why it is just me from home. So I'm going to try and share my screen and make sure that's working. Okay, here we go. Obviously, normally I have the handy thing of being like, does that work? Can you guys hear me? But we don't have that this time, so I guess I'll find out when the video stops. All right, here we go. So, oh no, I'm giving it away. Okay, here we go. So hopefully you guys can see that. Um, and we should be all good to go. All right, so this is your last week of life control. And what we'll mainly been focusing on is dementia, delirium, and anxiety. So let's get started. The first thing I have to do is basically apologize. Because you do have a lot of lobs this week. It's your last week of life control, so neuroanatomy is obviously incredibly important, and this is the week they try and fill in everything about the cerebrum that you might have missed. So everything about the frontal cortex, all the little bits of it, where things like Broca's are located, and where Wernicke's is located in the temporal, exactly where the occipital like vision stuff is, all of that week. My advice is just go to the lectures. I'm not sure if you still have the same lecture as we did last year, but it was taught really well. And I think if I tried to talk you through right now, it would take me an hour and I'd do a worse job than your lecture. So I'm not going to spend the time doing that in this session because I think that you just have to learn it from the lecture. But what I have included is the article from Ken Hub about lobes of the cerebrum. If you have any single question about anything about the lobes of the cerebrum, I guarantee you will find it answered on this page. It has literally every single possible thing you could need. So if you're wondering, am I going too deep? Um, yeah, you will not need to know more than that is on this page. So I've left the link to it there. I think it's just going through it and finding the best way that memorizing it works for you. But as I said, I'm not going to focus on it this time because I will just be pointing at things and saying what the name is called. So there we go. Moving on. But you'll be fine. You will be absolutely fine. It's just going through all the things that, all the handouts, all of the like crosswords, spotters, or whatever the different things they give you. That's what they used to give us last year. If you just make sure you do them, you'll be absolutely fine. So why don't we go on to the big meat and potatoes of this week? Dementia. So I'm sure there might be many of you who've experienced dementia in your lives, from a family member or a loved one. I know I have as well. So I think it's actually quite a nice time this week to be able to get a bit more of a clinical picture about something that you've only seen in the real world. So yeah, let's talk about it. So first thing I have to say is that there are four different types of dementia. There's actually five because there's one called Parkinson's dementia, but it's not really included in the main four. We'll just talk about it later to kind of differentiate it from other things. But in terms of what you're really expected to understand, it's about these four. So the most common by far is Alzheimer's, followed by vascular dementia, Lewy body dementia, which is also called dementia with Lewy bodies, and frontotemporal dementia. So dementia is really an umbrella term used to describe a range of symptoms because the pathophysiology of each of these is quite different. Um, there's different ways you could learn this. We could go through each one by one, but what I've decided to do is try and do all of them at the same time. By which I mean, let's look at the different pathophysiologies for each of the four of them first, and then let's look at the risk factors altogether, and then let's look at the management altogether. I think it's just because that way it's easier to kind of remember which one is for which. I think sometimes if you go through each one separately, it can start to feel like you're learning four whole conditions. So let's see if I'm right or if this is really confusing. All right, so let's start off with the main one. We're going to talk about pathophysiologies first. All right. So Alzheimer's. So it's characterized by neuronal soul death and particularly cholinergic neuron death. So that's only important, the cholinergic part, because it will have an effect on the treatment and the pharmacological agents we use. And we'll talk about that later on. The neuronal death is selective, with the hippocampus, amygdala, temporal neocortex, and subcortical nuclei being the most vulnerable. So what you're really getting is your sort of hippocampus area. So if you imagine if you were seeing a view that's sort of face on of a brain, it's those bits sort of underneath that you'll see kind of wasting away, and also a lot of the temporal neocortex. So all of the cortex here, that's where you'll see a lot of the wasting. So you'll see some photos of that later on. The main thing to remember about this, and I am I'm not a biomedical sciences person at all. I came into medicine with the least amount of science, so I'm not going to pretend to understand the complex biochemistry behind this. But what's really important is, and they do ask a lot of questions about it, is understanding these sort of buzzwords behind each type of dementia. So the ones you want for Alzheimer's are beta amyloid plaques and tau tangles. So you can see I put them at the bottom. Amyloid plaques, tau tangles. So amyloid plaques, these are caused by accumulation of B-amyloid peptide, which is a degradation of the amyloid precursor protein. All right. Now, key is that amyloid plaques are found on the outside. So if you see this picture here, so you get these sort of sheets of beta amyloid peptide clumping together, and these cause neuronal damage by vicinity, but they're extracellular. And then the tau tangles, so these are neurofibrillary tangles, which are compromised of hyperphosphorylated, I don't really know what that means, but tau proteins. And these are actually inside the axons themselves, so it causes damage to the axons. So that's the key thing to remember is you have your beta amyloid plaques, and they are on the outside, they're in the vicinity, and they're causing damage. And then intracellularly, you have your neurofibrillary tau tangles. So these are endogenous proteins that you would normally find. It's just that it's a sort of misfolding that's causing them to sort of clump together. A bit like when we talked about sickle cell disease, you do normal red blood cells, but because of their abnormal shape, they end up clumping together, causing problems. It's a similar sort of thing. So yeah, Alzheimer's, remember amyloid plaques, extracellular, tau tangles, intracellular. That's the main thing to remember. All right. So and I'm going to keep doing them all in the same order. So next one is vascular dementia. So vascular dementia is a lot simpler. It occurs as a result of multiple arterial infarcts. So you've already learned about ischemic stroke. I don't remember if it was last week or the week before, but this has the same pathogenesis, the same risk factors, and the same sort of behavioral and focal neurological signs. So yeah, it's basically caused by chronic infarcts, and that just leads to the death of neuronal tissue and hence reduced cognition. All right, so that one's quite easy, I think. Frontotemporal dementia. So this is characterized by these things called pick bodies. These are kind of like tau tangles as well, but they're often called tau inclusions. But if they ask you a question about it and they're saying what type of thing is this, they will use the term pick bodies, or they really should. So even though the word tau is there again, for tau tangles, think Alzheimer's and think beta amyloid plaques Alzheimer's. For these, you might see it says tau inclusions, but if it says pick bodies, they're talking about frontotemporal dementia. All right. So these pick bodies are also intracellular, found inside neurons, and they lead to degeneration and atrophy, but of the frontal lobe specifically. So it's really this frontal and temporal area. And you'll see why that's important later, because this type of dementia is particularly characterized by behavior change and also issues with speech, such as aphasia. So yeah, that's your frontotemporal. Just look for that word, Pick's bodies. This is actually sometimes called Pick's disease, Pick's dementia as well. So yeah, we had our Alzheimer's, which was our beta amyloid plaques and our tau tangles. We had vascular dementia, which was just the same as a stroke, same as an ischemic stroke. You're just getting damage by ischemia. And then frontotemporal dementia is your pick bodies, which are causing the damage to the front and the temporal lobe. And finally, we have dementia with Lewy bodies. So dementia with Lewy bodies, this characterized by, again, misfolded neuronal inclusions, but these are called alpha-synuclein. Now, Again, it might seem like you've just got a horrible bunch of words to learn, but they should always call themselves Lewy bodies. I've never seen anything where it says this patient is found upon, biochemical analysis to have inclusions of misfolded alpha synuclein. It will always be Lewy bodies are detected. All right. And like Alzheimer's, these also result in marked reduction in cholinergic neurons. Um, but if you remember from your Parkinson's week and the substantia nigra, um, these can have a huge effect on that whole area as well. So in the basal ganglia. So they also have they also do affect the neocortical areas too, but it really is a lot of the basal ganglia that gets affected here, which is why you'll get Parkinsonism as a symptom. So Lewy bodies and dementia and Parkinson's disease, they are very, very much related, as you'll see going on. But yeah, for this one, technically the complex word is alpha synuclein, but really the word you need to know is Lewy bodies, and it's in the name. So there you go. We had Alzheimer's, which was tau tangles, beta amyloid plaques, vascular dementia, which was just ischemia. We've had frontotemporal dementia, which was PIC bodies in the frontal and temporal areas. And now we have, and they were intracellular as well. And now here we have misfolded alpha synuclein, which are known as Lewy bodies, and that's why it's called Lewy body dementia. And this also results in less cholinergic neurons, right? And this affects the basal ganglia. All right, so those are our four main types. Now let's go looking onto some presentation. So you'll find with all of this that Alzheimer's is the one that has the most information each time. That's the one they really want you to be super hot on, and that's the one I believe that your case is on this week. So one of the biggest things to note about Alzheimer's, and this will become important when we talk about delirium later, is it's a gradual onset, right? So it usually progresses slowly over 7 to 10 years. So again, I don't know if anyone out there has experienced or known someone with Alzheimer's in their life. It really is a very, very, very slow process. And in the early stages, all that happens is there'll be normal things that you might think of from age. So memory lapses, forgetting names of people, places, recent events or appointments, difficulty finding words. But it's that sort of difference, and whether you see this on placement or at GP or just in questions, I would say, if someone's forgetting the name of a film, my mum does that constantly. It's like her special talent to get the names of films wrong. It's adorable. Um, but yeah, for example, I remember with my grandmother, sometimes, when her Alzheimer's started to get worse, she would write someone a check and then 5 minutes later write the same check. And then 5 minutes later, the same one. Or, she would cook dinner and then eat it and then cook it all over again. So it's a much more serious memory lapses. That's what you got to think of with Alzheimer's and how you kind of have to judge it. But in the early stages, it's very difficult to differentiate from just normal aging. Um, so yeah, and then as we get progression, we get difficulties with language, apraxia, planning, decision making, confusion. I think confusion's the big main one there. And then late stages, these are the ones we're a lot more familiar with, which is our wandering, our disorientation, and we can also get psychiatric symptoms. I would be wary of the fact that it says hallucinations there. People can get hallucinations and can get evident moments of psychosis um, if they have severe cognitive impairment. There's a thing known as sundowning, which is when people with cognitive impairment are, for example, doing fine, but then when it gets dark and the environment seems unfamiliar, for example, in somewhere like a hospital, they can start to get quite intense sort of delusions and beliefs. So psychiatric symptoms is the key there, and also behavioral problems, so disinhibition, aggression, and agitation. I think in your case this week, your patient, he had quite a lot of agitation. He was forgetting words for things, but he was also getting quite agitated and quite frustrated at his partner over very small things, which again may sound like a normal aging person, but it's just putting it all together. So I think the main thing you want to think about, especially in a question about Alzheimer's, is it's this long, gradual onset, starting from kind of basic memory lapses through to difficulty with language or confusion, and finally ending in psychiatric and behavioral problems. All right. And actually, a really handy way to think about it, I forgot I put this in here, and this is actually really worth memorizing because I think I've even seen questions about it before. It just makes it easier to talk about. So anosognosia just means that you don't know there's something wrong. So, you don't think you have a memory problem. You don't understand why people are claiming you need help because to you everything's normal. Aphasia means a difficulty in using language, the famous one being Bruce Willis earlier this year, or I should say late last year. Altered perception. So you misinterpret the information your senses are giving you. This is a bigger problem in the late afternoon or early evening when light changes. So that's what I said about sundowning. Know what apathy is. Agnosia, which is sort of no longer recognizing things from your senses, which is, I think, a very late sign. Apraxia, which is, just having troubles. I try to say problems and troubles at the same time. Trouble carrying out purposeful movement, and amnesia, which means loss. To remember it, you can either kind of think of it clinically by going through, or you can go more along the lines of remembering those 7 A's. So there you go. Vascular dementia. Now, like I said, if you're feeling like, oh my God, this is so much to remember every time, Alzheimer's is the big one. All right. All these are a little bit smaller. So the big thing you want to think about with vascular dementia is stepwise decline. Now, I know it says not always, and in real life, for sure, it won't be always. But in terms of request, that will be a sort of defining characteristic. So if you have a patient who has, in a vignette that has type 2 diabetes and hypertension that's poorly controlled and had previously had a stroke and now they're getting cognitive that have been okay and then they slowly get worse and then they stay the same for a while and get worse, that's when you want to think about vascular dementia. You'll notice I haven't put along specific focal neurological signs, and that's because it depends on the location of the infarct. So, for example, if you had an infarct in back here in your occipital cortex, you could have problems with vision. It's the same with anything to do with your stroke. All the different areas, whether it's your middle cerebral artery, anterior cerebral artery, it's going to give you different sort of neurological signs. So the big thing to remember is focal neurological signs, depending on where the infarct is, and stepwise decline. And this is from the bottom thing is from a lecture you guys are going to have this week. So they talk about these things as well as like patchy deficits. So symptoms staying the same for a while, suddenly getting worse, and it can often be things to do with attention impairment, language impairment, and nighttime confusion. Don't worry about this thing that says Hachinsky ischemic score. I've just included it there because they will talk about it in your lecture this week, but it's the fact that often there's some crossover between vascular dementia and Alzheimer's, and often it's quite difficult if they present quite similarly. So people use a thing called the Hachinsky ischemic score, which is just basically a sort of screening test to see if it's more likely that you have a vascular dementia rather than Alzheimer's. Okay, so the big thing to remember there, stepwise, and then cardiovascular risk factors. Lewy body dementia. Now, the big one I want you to remember is hallucinations. Hallucinations. This is the big one, especially in any question or any vignette you're going to get about Lewy body dementia will be about hallucinations. Okay, so it's not that they're impossible in the other forms of dementia, but the key thing here, and I'm going to skip all the way to the bottom, you can see when I put the NB, symptoms typically occur before Parkinsonism. So if you read a vignette and someone has started seeing things that aren't quite there, and for example, I just did a past med question today that just came up randomly, where a woman was having some cognitive problems, and she started to talk about her gardener, and her grandchildren have realized that she doesn't have a gardener. She's also started showing some problems with her movement. So that's a classic sort of picture of Lewy body dementia. You're having these hallucinations and features of Parkinsonism. Sorry, excuse me. There can also be issues with bladder and bowel. And like any form of dementia, there can be issues with apathy and depression. So, yeah, the big thing is, like I said, there is another type of dementia which is called Parkinson's dementia. The key thing with Parkinson's disease and Parkinson's dementia is that what will happen is your motor symptoms tend to present before your cognitive symptoms. So if you see a question and it talks about someone's having, features of Parkinsonism, so resting tremor, bradykinesia, rigidity, but they're also having hallucinations and cognitive problems, just have a look at which one is happening first. So if you're getting the cognitive problems and the hallucinations, then you're getting the motor symptoms, think Lewy body dementia. If you're having the motor symptoms first and then it's causing cognitive decline, that can happen in Parkinson's disease. And there's actually, like I said, something called Parkinson's disease dementia, which is just a kind of sort of almost like end organ damage, if you will, from Parkinson's. So that's a big thing here. Hallucinations, Parkinsonism, but just if the cognitive stuff comes first and the hallucinations come first, think Lewy body dementia. All right, and then finally, frontotemporal. So big thing about frontotemporal is it's behavioral. So this is, I know this might seem like quite a complicated diagram, but if you think fronto and temporal, your frontal lobe is really key for who you are and all of your behaviors. So it's natural to think that the two main ways that you would have frontotemporal dementia present would be with behavioral changes and with problems with language. So if you follow this sort of chart here, yes, we have three different types, but the first one, behavioral variant. So this is changes in social conduct behavior, loss of empathy, loss of apathy, disinhibition. I think I'll have a lecture this week that involves a man in the 40s who had a horrific head injury where he had a pipe stuck through his frontal lobe. And they managed to remove it, but afterwards his behavior was incredibly different. He had very little empathy, very little disinhibition. Um, so that's your sort of classic behavioral variant, and that often comes up in questions. The other thing to think about is fronto and temporal, so Broca's and Wernicke's, and then I think it's called the arcuate something, I can't remember, in between. That's your whole understanding and speaking and finding words and semantic use of language. So that's why you can get primary progressive aphasia, and that can either be from semantic dementia, so that's loss of semantic knowledge, impaired word comprehension, and object naming. So I think that's even though he didn't have frontotemporal dementia, that was a problem your patient was having this week with Alzheimer's. So there's a lot of crossover with all these things. Um, or you could have progressive non-fluent, which is you understand your object knowledge and word comprehension, but it's really difficult to speak. It's actually the sort of motion of speaking, a bit like when we talked with Parkinson's. Parkinson's isn't that you can't move, it's often making the decision to move because the basal ganglia is about decision making. It's a similar sort of thing here. So yeah, I hope that's a bit of an overview. But if you see anything about behavior changes, or you see things to do with aphasia, so whether that's losing sort of semantic knowledge or whether that's about the difficulty actually speaking, then think about frontotemporal. All right. So I'll just go back to make sure because I like to go slowly. Alzheimer's, there's a lot of stuff to learn. You can remember it by the 7 A's or just kind of have an understanding of it. Vascular dementia, it's these stepwise progressions as things stay same for a while and then suddenly gets worse and then plateaus again. And look for cardiovascular risk factors. Lewy body dementia is our hallucinations and cognitive problems happening before Parkinsonism. And then frontotemporal dementia will be characterized by behavior change or problems with language, known as aphasia. All right. So let's carry on. Risk factors, I've just kind of put them all on the same page. It is worth kind of knowing some of these. Vascular dementia here, right in the middle, nice and easy. It's all the CVD risk factors, so I'm not even going to go through that. Alzheimer's has a couple of interesting ones. It is much more common in females, but that can also be due to the fact that, sorry, not much more common, it just is more common. And that can also be due to the fact of obviously the increased life expectancy and age being probably the biggest risk factor for dementia. In terms of early onset dementia, so there is a gene that is, I believe I think the gene that causes this early onset is actually on 21 pair of chromosomes. So if you have a trisomy 21, so Down syndrome, you're pretty much guaranteed to get earlier onset Alzheimer's. So early onset Alzheimer's is a big, big link with Down syndrome. But in terms of late onset, how most of us think of Alzheimer's, your typical patient, you're looking for her to be older, over 65, female, looking for an APOE4. That's a gene which has often been linked with Alzheimer's, and also vascular disease, unhealthy lifestyle. It says pre-morbid mild cognitive impairment. So that's it can often be with people who've maybe who've really struggled with learning difficulties, And I don't mean in terms of special educational needs. It can often be to do with trauma, either emotional or physical. It's basically the idea that if you have had some problems with your cognition that are not pathological, it's linked with Alzheimer's as well. So people don't really know why Alzheimer's happens. These are just the kind of things to look for. So early onset, think about trisomy and Down syndrome. And if we're talking about the late onset Alzheimer's, think over 65 female. And if they do ask a question about genetics, look for that APOE4. Lewy body dementia, more common in men, older. Just look for family history and Parkinson's disease. I think you kind of older male Parkinson's, actually a sort of typical patient there. To me, with risk factors and epidemiology, the reason it's important to know is just so you can pick out your typical patient in a vignette. Also, when you go onto placement, it's actually important to be able to recognize things and treat people. But I just mean, for your exams. And then frontotemporal dementia, there's no known risk factors. There's just often a genetic and family component. So just look for the family history. All right, I'm going to move straight on. Come on. Yeah. All right, so imaging. So I talked about this a little bit before. So if you were to see an MRI scan of someone with Alzheimer's disease, so this is a coronal, that's the word I was looking for. So this is a coronal view of the brain. So if you imagine you're looking at it either straight on or you're looking at it from the back, but either way, we're looking in this plane, coronal. Sorry, as if we've chopped through directly horizontally through me now. So looking straight at my brain here. So you can see here that because that atrophy we talked about is in the hippocampus and the temporal cortices, the outer temporal cortices, what you get is the sulci are much wider, the gyri are much narrower, and the ventricles increase. And also you can see here on the one on the left, you've got this nice sort of rich area where you're going to be having your basal ganglia and your substantia nigra, your subcortical areas, and they're also waste away a lot. So that's why having that sort of coronal view is really helpful for Alzheimer's, because you can see the wasting all along the sort of temporal regions on the outside of the brain. I know, sorry, that also goes to up here, it would be frontal or parietal, but you get what I mean. It's these sort of areas here that you notice the wasting in the temporal areas, and also around the sort of basal ganglia area, substantia nigra, and also because of that, the ventricles will also appear larger too. So widespread cortical atrophy, that's the main thing you're looking for. And then very quickly, dementia with Lewy bodies is a clinical diagnosis. You're not going to get a picture or an image to do with that. But just vascular dementia, you can see for the image here, we've got all of these different spots here, which are showing areas of multiple infarcts. So that's the kind of thing you'd be looking for as well on a CT or MRI infarcts. And in frontotemporal dementia, you can see that we've got some atrophy here. If you imagine that the white you're seeing is just fluid. So at the back here, you've got these nice, juicy gyri and very small sulci. But here in the frontotemporal regions, the gyri are a lot narrower and the gaps are a lot bigger, which is why there's more sort of fluid. That's not pathological fluid. That's just the fluid that you have surrounding your brain, the CSF. But you can see here, it basically just means the brain's wasted away a lot at the frontal and temporal regions. All right, so simple enough. But yeah, normally if you see something, it will be this sort of classic sort of MRI of Alzheimer's with the degeneration along here and around the basal ganglia areas. All right, so now let's move on to diagnosing. So ICD-10. So most diseases, I mean, the ICD classifications will encompass everything, whereas DSM, we tend to use DSM classifications for mental illness. But in this case, because this is kind of both, we're going to go with ICD. So diagnosing dementia, what you need to see is a decline in memory, both verbal and nonverbal, decline in other cognitive abilities. Awareness of environment is preserved, i.e. not delirium. So we'll come back to what delirium is, because that's a big thing this week, being able to tell the difference between dementia and delirium. Decline in emotional control or change in social behavior, and these symptoms need to be present for more than 6 months. So how do we do that in a more formal way of diagnosing? Let's find out. Okay, so what you're going to do is take a huge collateral history, which you would have done in your case this week. That's huge. It is still mostly a clinical diagnosis. And obviously we'll do an exam as well. That can be really useful in terms of things like speech, or if they have any of those deficits in their sensory abilities. I don't mean sensory as in touch or paresthesia or numbness. I mean, in terms of smell, sight, sound. One of the biggest things that you'll often see, happen in your case this week was the mini mental state examination. It's good to have an idea of that this week. It should be important to know it's not diagnostic, but it's a useful screening tool. And what happens is it's often done in primary care. So if you're someone's in primary care and you just want to get a quick idea of their mental state, that's where the mini mental state exam would come in. There are lots of other different exams. There's the mocker, there's a tons of other different ones. But I remember the one they wanted you to definitely understand this week was the mini mental state exam. But when you get into secondary care, then you would get an abbreviated mental test score. We won't go into that in detail today, but we will just focus on the mini mental state exam. And in secondary care, that would be something a lot more official, like the abbreviated mental test score or the mocker. Right. So, bloods are worth doing just to exclude other treatable causes. Same, looking for blood sugar is a big one for looking for hypoglycemia. Neuroimaging, the MRI scan, which we talked about already, and an LP if a rapidly progressive form of dementia is suspected. However, the big thing you want to really take from this is history and your mini mental state exam. If you were seeing a patient for the first time, that's something you can do on the spot. And if that's a useful screening tool and you have fears of dementia, that's when you can refer to specialists and refer to secondary care. So let's, this is a more, clear way to do it. So say the GP does the mini mental test score, and mini mental state examination, and then they refer to a memory clinic because they have concerns. Then you'd have history, a full cognitive test, getting a collateral history because that's really important as well. Getting a history from someone else who knows this person, because if they have anosognosia, not knowing that there's a problem, then their history is not going to be very reliable. And then we can query looking at imaging and just check for any other reversible causes. And then, that can either lead to no signs of a cognitive problem, mild cognitive impairment, or a diagnosis of one of these dementias. So that's sort of your diagnostic pathway. And let's just have a little look at this mini mental state examination a bit more clearly. So it assesses 5 areas of cognitive function: orientation in time and place, registration, so that's non-related objects, attention and calculation, recall, language, and copying. So let's go through each one by one. So you can see orientation in time and place. It starts to say, what season is it? What month is it? What's the date? What's the time? It's these sort of things, checking someone's orientation in time and place. Registration, what they're doing here is naming 3 objects and then asking the patient to repeat it. So what you're getting someone to do is, for example, saying apple, table, penny. They need to be able to understand what those things mean, and then that's testing your understanding, your semantic, your ability to speak, everything. Attention and calculation. This is serial 7s. So what happens here is you go, I think this is quite difficult personally, but someone say subtract 7 from 100, and then repeat again and repeat again. Alternatives, if people have problems with maths, you could ask them to spell a word backwards. This is not about getting the right answer. It's about attention because it requires constant cognitive working. Recall, very simple. It's just asking for the names of the 3 objects that you went through earlier. And then language and copying. So this is asking people to name what is this, what's this, getting them to repeat certain things. So for example, no ifs, no ands, no buts, or giving a 3-stage command. So this again is just sort of testing these little things of whether you are having issues with your language. So generally, 14 to 30, we're looking at normal. 18 to 23, sorry, that's not correct. It should say 20, I apologize, I will change that on the slides. That should say 23 to, it should say 24 to 30, normal, so no cognitive impairment. 18 to 23, mild cognitive impairment, and 0 to 17, severe cognitive impairment. However, for Alzheimer's, we often have a sort of different scoring system. So anything between 21 and 27 is considered mild, 14 to 20 moderate, and 10 to 14. So yeah, here we go. I think I've messed up some of the numbers there, but that's basically just what it is. You won't need to know every single number, but just having an idea would be good, and I'll change the numbers on the slides. So now let's think about management. So the biggest thing in management is a memory clinic. So people who are diagnosed with dementia will attend a memory clinic and receive long-term care. And I know it's really exhausting learning all these MDT labs, but that is basically what will happen here. There'll be an MDT. So there'll be a psychiatrist who assesses, diagnoses, and manages medical care, community psychiatric nurse. This is someone monitoring the patient's mental state and risks while supporting carers. A big one that happens a lot, occupational therapists. So, for example, if you are on a ward and somebody maybe has come in for, I don't know, a renal issue, for example, or community-acquired pneumonia, but they are someone with a cognitive deficit, and you're wondering if you're able to send them home. Do they have a safe place to go to at home? Can they be returned safely to their home? That's where occupational therapists come in to assess the patient's home environment, their skills and abilities to carry out their activities. So they're really important. Psychologists can help, particularly if there's a behavioral aspect to it, and social workers to make sure they're getting their needs cared for. So that really is the mainstay of treatment across all dementia. As I'm sure you're aware, there isn't a cure for any of them. However, one thing it is worth noting is, if you remember earlier on, I said that Lewy bodies have a marked reduction in cholinergic neurons. I also said that Alzheimer's has cholinergic neuronal death. So for these two, we do actually have some pharmacological interventions that are to do with the fact that it's cholinergic neurons that are affected. So what we're doing here is we want to give treatment to increase the levels of acetylcholine in the synapses. So what we do is we use cholinesterase inhibitors. So basically, cholinesterases are imagine that there's acetylcholine within the synapse. Cholinesterases are these sort of enzymes going in and mopping that up. Once the synapse is fired, they come in and mop it up. But because we're having such a decrease in cholinergic neurons and a big lack of acetylcholine in general, these cholinesterase inhibitors, by inhibiting those enzymes that normally come along and mop up the acetylcholine, by inhibiting them, it means there's just more acetylcholine around, which means the neurons can function slightly better and we can have less of a cognitive deficit. So yeah, that's the way to think of it. These are cholinesterase inhibitors. So again, I'll just say it one more time. If you imagine we have a lack of acetylcholine, normally acetylcholine is giving the information in the synapses. Normally cholinesterase comes in and mops up the acetylcholine we don't need. In a healthy person, that's great. But in someone with a huge deficit in acetylcholine, if we can inhibit those cholinesterase, those little enzymes that are mopping it up, if we can inhibit those, then it means we'll have more acetylcholine around and the synapse can function more effectively. So I hope that makes sense. The biggest one you want to remember is donepezil. Donepezil, I should say. Donepezil, which is taken as an oral tablet, and rivastigmine can also be given. However, the main other thing to remember is that there is a second line, which are NMDA receptor antagonists, and this is memantine. So if someone is going to be given some treatment, pharmacological treatment for Alzheimer's, the first thing they'll be started on is donepezil. If they can't take donepezil, it would be rivastigmine. And if another drug was going to be added on, it would be memantine. So first line, donepezil. Memantine is only given as a monotherapy in really severe Alzheimer's. And again, I only know that from really random past med questions, so I wouldn't focus on that. Main thing you want to think is pharmacological treatment, donepezil, possibly with memantine. All right. Memantine can also be given if, for some reason, all cholinesterase inhibitors can't be tolerated. So that's the main thing to remember. I'm not going to go into a huge micro of all its contraindications and blah, blah, blah. That's not the biggest thing of this week. But if you can remember donepezil, memantine is the second line, and just know what rivastigmine and galantamine are. Galantamine is not really used anymore. But if you can just remember those sort of buzzwords to do with Alzheimer's and Lewy body dementia, and remember how they work because they're cholinesterase inhibitors, and remembering that memantine is an NMDA receptor antagonist. I'm not going to go into why exactly that helps with everything. You can have a look into it yourself. I don't even remember properly, if I'm completely honest, but I do always just remember it's an NMDA receptor antagonist. So there you go. That's your pharmacological management. It's only for Alzheimer's and Lewy body dementia. Donepezil, second line, memantine. All right, how are we doing? Wow. Okay. Smash through it. We got through delirium. All right. If you give me 2 seconds, I'm going to get something to drink. You can also get yourself something to drink, should you wish. And then I'll continue. Ooh, Alrighty, and we are back. So here we go. Delirium. So notice I mentioned the DSM-5 before. That's because delirium is more classed as a psychiatric or condition, which is why we're using the DSM-5 definition. And you'll notice when we talk about anxiety later, that will also be using DSM-5 definitions. So delirium is a disturbance in awareness and attention. This disturbance develops over a very short period of time. So we want an acute change in baseline attention and awareness, often fluctuating within the same day. There can be additional disturbances in cognitions. These disturbances are not better explained by a pre-existing neurocognitive disorder. So we need to be able to say to ourselves, this is more likely delirium. This is not being caused by dementia. Someone with dementia can also get delirium, but it needs to be not better explained by a pre-existing neurocognitive disorder. And we also need to have direct evidence that the disturbance is a direct physiological consequence of another medical condition. So, one that people might know very much is UTIs. In elderly people who are susceptible can actually cause delirium. So, really, that was a lot of words. The main thing you need to know about delirium is that it's really bloody similar to dementia. And that's the problem because they love asking questions. What about this patient's presentation makes it more likely that they are delirious than it being just a natural onset of their Lewy body dementia? It's knowing what is it that differentiates delirium from dementia. And the really thing to think about delirium is it's an acute disturbance in attention and awareness, and it's almost always the direct physiological consequence of another medical condition. So a classic one being UTIs, right? So let's have a look. So potential causes of delirium. So we said about the different things that will be causing it. So pain is the person in pain. Urinary retention, that can also cause a UTI and lead to delirium. Infection is a very common cause, like I said, particularly UTIs. Constipation, that's a big one in elderly people, causing delirium. Hydration and nutrition, so major electrolyte balances. Also hypoxia, hypotension, hypoglycemia, even things that might cause a sort of cognitive change in a young, fit, healthy person. Medication, so omission or addition of a new medication could also precipitate delirium. And also big one, change of environment, noise or activity. So change of environment, like I said, is huge. So for example, if you have an elderly person who normally lives in a care home and then they've developed a UTI and gone into hospital, and let's say that there's any bacteremia, that UTI can then, and being in a brand new environment at night that they don't recognize, and with the sort of fluorescent lighting, is a classic sort of picture of what can lead to delirium. So, and it forms the nice little mnemonic of pinch me. All right, so pain, infection, nutrition, constipation, hydration, medication, environment. The ones I would really remember from there is infection, constipation, and environment. Those are big, big ones to remember. But what we really need to be able to do, and I give you another mnemonic here, is OCD camps. And this is the things you need to think about in how will I differentiate them. So let's just go through it slowly, right? Onset, delirium, rapid, dementia, insidious, months to years. Really important. Course, sundowning is mentioned here, which I talked about earlier. fluctuating, so it can depend on the time of day, but again, acute. And in dementia, we're looking progressive. So if someone's, sort of cognitive things are coming in and out every couple of hours, that's not a classic sign of dementia. And changing day to day, there's a more of a delirium thing. I know we said that in other forms of dementia, you can get fluctuating sort of patchy deficits, but again, it's an overall progressive sort of picture compared to fluctuating. Duration, delirium is acute, so days. I mean, I've not heard of cases of weeks, but days really. Dementia, irreversible, months to years. Really big one here. Conscious level. So they put as consciousness here, but conscious level is altered in delirium. So in someone with dementia, they don't tend to be going in and out of consciousness. If you have a patient who's sort of not listening and then is there and then is unconscious and then is and is kind of listening to what you're saying but then not able to pay attention, that's not common of dementia. Dementia would be having problems understanding what you're saying, understanding what the words mean, remembering what you were talking about, remembering where you were going. But your conscious level in dementia is that of a sort of young, fit, healthy person. Whereas in delirium, that kind of fluctuates. So someone coming in and out of consciousness is massively key of delirium. Attention. So even though attention can have a deficit in dementia, that kind of goes along with consciousness as a big inattention thing with delirium. Memory. Um, yes, short-term memory happens in both. I think the point they're trying to make here is that in dementia, if I said, hello, my name is Adam, what did I just say? Someone who has Alzheimer's might still be able to repeat those words back to me, possibly. But in delirium, because someone's cognitive state is so all over the place, they might not even be able to do that. In delirium, people are often hyperactive, so that's your psychomotor changes, a lot more hyperactive. And sleep-wake cycle, you're not going to get a question about that. So your big thing you want to look at is onset. Has it been rapid? Has it been acute? Has it been fluctuating throughout the day? Has a new environment or a new time of day or new lighting set it off? That's much more delirium. Is their conscious level altered? Huge conscious level altered. And also, are they hyperactive in this sort of, are they getting angry? Are they getting super agitated? Are they sort of having delusions? Again, it can be a bit of an overlap with, Lewy body dementia with your delusions and hallucinations, but we're talking sort of someone talking to you 1 second and then the next moment jumping out of bed, holding something, being there after me, they're coming for me. It's that sort of acute and that sort of fluctuating, like semi-unconscious delirious level. I mean, think about the word we use, delirious. So I think when you get a question, which you'll probably get them in practice questions or in an exam that's like, what about this person's presentation suggests delirium more than dementia? Or just kind of go through this and think, well, what's the onset? What's the course like? Has it been acute? If it shows someone and it says, what about this is more to do with delirium? Look for things that are acute or have fluctuating consciousness or have delusions or, a recent history of something like a UTI or pneumonia. Those are the sort of things to look for. All right. And you can watch this video, which I've left the link to, which will say much of what I've just said, but, in a nice way. All right, guys, we're going to move straight on to anxiety disorders. So it's quite a few to cover here, but the only ones to really go in depth with is to do with generalized anxiety disorder. But let's start from the beginning. So what is anxiety? The best way to think about it, they put it here as chronic excessive worry, which is not related to particular circumstances. I think in this picture you can see on the right, I really like this. It's just stress often happens in response to a recognized threat. I'm stressed because I'm under pressure at work because they're laying people off. Anxiety may not have an identifiable trigger, or if it does have an identifiable trigger, such as, oh, I get really anxious when I'm talking to new people, or I get really some people get really anxious in hospitals. You might have a trigger there, but it's not to an actual recognized threat. You could be, if you are someone with a huge amount of social anxiety, you could be in a room full of people who actually only think positive things about you and are only showing sort of positive sort of social cues. But if you have a high enough level of anxiety, just that situation will trigger that. So I think trigger is not the helpful word. It's more about stress being is in response to a recognized threat, whereas anxiety might not have an identifiable trigger. And even if it does, it may not be related to an actual thing that's happening right now. It's more an idea that is triggering you. And the other big thing about anxiety that they put here is its symptoms of physiological arousal, so such as restlessness, insomnia, muscle tension. So that's a big one to look through. If you're getting a question that says, which of these symptoms is more a symptom, is a typical symptom of anxiety rather than depression, look for physical things. So restlessness, muscle tension, sweating, nervousness, feeling uneasy, faster heartbeats, faster breathing. And as many people who have issues with the digestion will tell you, having huge amounts of anxiety can also disrupt your bowels as well. Many friends who said when they have huge amounts of anxiety that they really notice it in either diarrhea or constipation, which it just must be really horrible. So there you go. That's your big thing about anxiety and how it's different from stress and depression. We're looking for not an identifiable trigger. It's not kind of in a short term. It often lingers and continues, and we're looking for those physiological symptoms accompanying it. There are 5 main anxiety disorders: generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, panic disorders, social anxiety. Obsessive compulsive disorder, I hope that most of you will know what that is. You're not going to cover it this year in detail, but I think hopefully it's got enough sort of visibility in popular media by now that people know what the symptoms are to look out for of OCD. So if that comes to you roguely in a question, I will trust you guys to be able to pick out what those symptoms are of OCD. You're more likely to get asked about generalized anxiety disorder, and most of your lobs this week are based on that too. So let's carry on and talk about um, generalized anxiety disorder. So I said before, ICD-10, ICD is for categorizing all conditions. DSM is specifically to do with mental health. So let's look at the DSM-5 categorization. So first of all, we need to be present for 6 months, which if you think about it, is a much longer period than when you guys covered depression last week. I actually can't remember, but I think the depression limit can be as low as 2 weeks sometimes. So 6 months is quite a long time you need to be present. You need to prove it's not related to another mental disorder, medical condition, or substance abuse. And often there'll be quite an overlap between people with generalized anxiety disorder and substance abuse, particularly people who smoke weed. So again, you want to sort of prove if someone's been smoking weed that their anxieties have been sort of starting before that, as opposed to it being a sort of reaction to substance abuse. And what they also want is 3 of the following symptoms present most of the time. So restlessness, nervousness, easily fatigued, poor concentration, irritability, muscle tension, and sleep disturbance. So if you noticed from that, only 2 of those are actually psychological symptoms. Sorry, restlessness, nervousness is psychological, I guess. But your point is, it's pretty much like 50-50 there. We're talking easily fatigued, muscle tension, sleep disturbance. It's a big physiological aspect to this that is not required in as many other mental health disorders. Yeah, so that's all you sort of need to know about diagnosing it. Managing it, what we're going to have a look at is a stepwise approach. This is exactly what NICE does suggest. So, for example, early on, you might just have education about generalized anxiety, active monitoring, seeing if it's carrying on. If it is carrying on and, over 6 months and becoming, a quite significantly diagnosed generalized anxiety disorder, then you can look at low intensity psychological interventions. So these can be guided self-help or unguided self-help or psychoeducational groups, support groups, that sort of stuff. But if you're going to get asked about a question, then it's going to be step 3. And normally in the questions I've seen, it will say, oh, they've tried to manage it on their own. They have support from their partner, but they think they need more help, or they go to a support group, but it's not enough. So the question will be leading you to what are your drug treatments or high intensity psychological interventions going to be? So your big one for generalized anxiety disorder is cognitive behavioral therapy. I think you should have a good lecture on it this week. I think you also have a lecture this week on who's suitable for therapy, and that has kind of come up in some questions, but I haven't gone deep into, the sort of model of cognitive behavioral therapy and exactly how it works. You can get that from your lecture if you need. The main thing to know is that it is really the mainstay in anxiety disorders. So people with depression, I know CBT comes up a lot as well, but there are other forms of therapy that are really sort of valued when it comes to um, when it comes to depression, whereas with generalized anxiety disorder, we really are looking about CBT. The other thing you're mainly getting asked is about pharmacological treatment. So just like with depression, we are looking at a first line SSRI. So with SSRIs, just know your main ones, sertraline, citalopram. Like, I think you are unlikely to get a question going, which one should they be started on out of sertraline and citalopram? I mean, if they do ask you, the answer is sertraline for an anxiety disorder, but normally they will only put one SSRI on there. And I think they're normally quite nice at George's. They'll, if you have forgotten what their names are called, they normally write afterwards SSRI. But just in case, sertraline is your first choice. If sertraline is ineffective, you can offer an alternative one, such as citalopram or escitalopram. Um, However, um, if that also hasn't been working, then you can offer a serotonin noradrenaline reuptake inhibitor. Again, I think you are unlikely to get asked that. But it's just knowing that SSRIs are first line. If it's not working, try another SSRI. If that's not working, try an SNRI. But really, just main thing to remember, sertraline, right? If they can't tolerate either, you consider offering pregabalin. But again, I've not seen that or heard anything about it. Um, Benzodiazepines, so diazepam is the big one. You might have had friends or known people who get panic attacks, and or who for flying have been prescribed diazepam. Yeah, just generally doctors don't like prescribing diazepam at all. So if you see it in a question, it's a no. I took one once by accident, not realizing someone was like, "Oh yeah, this is just like a." It was a long story. Point is, it was very good fun, but it very much is a like drug. It it very much is a drug, so doctors do not like prescribing it, um, and particularly for anything chronic. So it's only for people with really strong histories of panic attacks, or people in crisis, or who, for example, have a massive fear of flying. Because yeah, from personal experience, I can see why it would be very addictive and why no one would prescribe that. So yes, I just always, whenever I see diazepam, I'm like, no, that's not the answer. Unless it's for, unless we're talking about epilepsy, which you will cover next year, or we're talking about a really intense situation like a huge fear of flying. Maximum of 2 weeks prescription is advised for that. All right. All right. So, guys, we have come to the end. I've got it through basically just in 1 hour. And like I said, that is probably because, I haven't gone through a big in-depth neuroanatomy review with you. But like I said, it would have taken me an hour to do it, and I would have done a worse job than your lecture. Um, and I think it's much more useful for us to kind of go through and explore dementia. So, but make sure you do go to your lectures, and I've put that Ken Hub thing up there, the link to the Ken Hub. Anything you don't know, just go and know it, know where it is, know what it looks like. It's literally like just like a picture book. The questions can just be like, oh, what's this? So that's the kind of, just learn your neuroanatomy as best you can, and go to your sort of consolidating lectures you have about the lobes of the cerebrum this week. So let's go through the questions then quickly. I could just leave these for you, but I'm just going to talk through them just in case you have any, you see what the right answer is and go, wait, what? Why is that the right answer? Then at least you'll have an explanation. So question one, a 69-year-old man who is known to have Alzheimer's. Oh, also, I'm not sure if this is allowed or illegal, but it's what I've done. I actually decided not to write these this week, because I know a lot of the time, when you're watching peer teaching, or, you're thinking, what are the actual questions going to be like in the exam? I've got these off of PassMed. So these are actual questions that are from PassMed, which is not just used for passing your medical school exams, but it's also using for passing specialities exams that actual doctors use. So these are real questions. I've not doctored these. I've not changed them. These are real questions. All right. So I don't know if that's allowed, but was it because I was lazy, or was it because I thought it would be good for you guys to have real questions? I don't know. All right. Here we go. So, question one: 69-year-old man who's known to have Alzheimer's disease is reviewed in clinic. His latest mini mental state examination score is 18 out of 30, suggesting moderate dementia. According to NICE guidelines, what further action should be taken? So, the answer is there you go. So you'll notice none of the other ones had donepezil there, and that is your first pharmacological treatment. Someone having moderate dementia, 18 out of 30 is not a brilliant score when you look through that mini mental state exam. Um, so yeah, anyone having moderate severe dementia, you're going to start them on some treatment, and that would be donepezil. Supportive care is kind of a given. So there you go. Hope that's clear. Question two: a 79-year-old man with a known history of mixed type dementia, so Alzheimer's and vascular, is assessed in memory clinic as his family have noticed a further deterioration in his memory and cognition. Memantine is added to his pharmacological treatment regimen. Which of the following best describes the mechanism of action of memantine? So I'll give you a few more seconds. NMDA antagonist. Exactly right. So the only thing you get confused there is your acetylcholinesterase inhibitor, and that is your donepezil. Yeah, dopamine receptor antagonists. These are used in Parkinson's. Serotonin receptor agonist. This is obviously used for SSRIs. Yeah, NMDA antagonist, memantine. It's a rogue question, but it's on here, so it could happen. So just know what the main mode of action is. All right, question three. A 90-year-old man presents with worsening confusion. He's a nursing home resident and is dependent on carers for most activities of daily living. He is usually able to have short interactions with members of staff, though often struggles remembering names and naming objects. Carers are concerned as he appears less alert than usual. He needs significant prompting at mealtimes and remains incontinent of urine. On examination, he scores 12 out of 15 on the Glasgow Coma scale. So, of all of this, which factor would suggest a diagnosis of delirium rather than dementia? And the answer is the impairment of conscious level. That's the big one, conscious level. So he seems less alert than usual. He needs significant prompting. It's that impairment of conscious level that's happening acutely. That's the big problem. Urinary incontinence is there to just throw you off a bit because of UTIs and delirium, but no, conscious level. That's the biggest hitter of all with delirium. Nearly there. Question four. A 21-year-old woman is re-reviewed by her GP for generalized anxiety disorder. At her last review, she was given information about GAD and referred for individual guided self-help. Unfortunately, despite these treatments, she's still feeling worried about most things for most of the day. She struggles to relax, and her family have noticed that she's more irritable. The patient is keen to try further treatment. However, this time she would rather try a medication. What medication would be most appropriate to prescribe for this patient? And given how long I went on about it before, even though three of those are SSRIs on here. Hopefully you will remember that the answer is sertraline. Self-explanatory. Final question. 85-year-old female presents with increasing forgetfulness. She is brought in by her daughter, who notices that she has been forgetting things and has been getting lost. Her daughter now cooks for her. She has also been talking about a man in her garden. Oh, right. Yeah. Okay. This is the question I did earlier, and then I included it. Sorry. She's also been talking about a man in her garden, despite the fact that she does not have a gardener. The daughter notices that these concerns were improving a few months ago, but has again gotten worse in the past 2 weeks. The patient reports poor sleep, where she remembers her dreams vividly. Her past medical history includes hypertension, hyperlipidemia, diabetes. She is on perindopril, rosuvastatin, and metformin. She has never smoked and drinks alcohol. Which of the following is the most likely cause of her presentation? I think this one could lead you down a couple of alleys, but there's only one where it really works. And that answer is Lewy body dementia. So yes, they tried to put you off by putting hypertension, hyperlipidemia, diabetes, leading you down to those CVD risk factors. for vascular dementia. They've also talked about the symptoms improving and then getting worse in the past 2 weeks. But if you remember, vascular dementia is not, it's not waves, it's a step down, step down, step down. So that's not typical of vascular dementia. And although you can get psychosis occurring as a result of Alzheimer's, really hallucinations should make you think of Lewy body dementia. And in fact, the past medical explanation was just that. Dementia with hallucinations. Hallucinations have been going on for a while. They're not acute. Think Lewy body dementia, unless they have had symptoms of Parkinsonism, diagnosed symptoms of Parkinsonism for years before the hallucinations. So yeah, Lewy body dementia is right. So thank you guys. A little bit shorter and sweeter than normal. Sorry you didn't have a co-host, but hopefully I've done my best to be entertaining as just my little old self. Yeah, when this goes out in the future, I'll be doing my exams and crying. But the best way to make me not cry will be to fill in the feedback form and say nice things or mean things. Either is fine. So much love to you all. Got this. Speak to you soon. All right. Bye.